Sorry I'm late. I'm Dr. Sherman Silber, and I'm the director of the Infertility Center of St. Louis at St. Luke's Hospital in St. Louis, Missouri. And sorry I'm a little bit late, but you can see I'm in my work clothes, and I haven't been playing around. We're very, very busy all the time. But now I'd like to answer any questions you might have, and I'll just throw them at me, and I'll be glad to help out.
Okay, the first question that we have is from Jennifer, and she wants to know, are there any non-medical approaches such as relaxation or meditation techniques that could improve her chances of getting pregnant?
Well, the question is there anything non-medical, any other approaches that can improve one's chances of getting pregnant? Well, yes, there's a lot of things, but there is a lot of fraudulent stuff out there, like fertility supplements and nutritional supplements, DHEA. I mean, there's all kinds of really silly stuff out there that unfortunately floods the internet, and you can be fooled by it. But here are a couple of things. Everybody wants to know, when is the best time of month to have intercourse? What's the best time of the month to try? When do I ovulate? Well, let me explain something. The sperm are good for 2 or 3 days in the female reproductive tract after intercourse, but the egg is only good for up to 12 hours after ovulation. So it's important to always have sperm there whenever you might ovulate. The ovulation predictor tests are very inaccurate. I know it's $1 billion or so industry, and you can buy them at your drugstores. I'm going to say something that you may not have heard before. I'm against doing that, because what usually happens is you time the time wrong, you create tremendous strain on your relationship, and you get it wrong. And if you have sex 12 hours after ovulation, well, it's too late, because the egg will be no good anymore. So I think there should always be sperm in your reproductive tract. So my advice is to forget about when you ovulate and just have intercourse 2 or 3 times or more per week. And that way there'll always be sperm there whenever you ovulate. So I think that's important. It's counterproductive to try to time your intercourse because now you want to get pregnant. And recognize that in the most fertile couples, there's only a 20% chance per month of getting pregnant. So you shouldn't be discouraged if after 2 or 3 months you're still not pregnant. We only recommend fertility treatment if you've gone for more than a year. So don't rush into, I think, incorrect, fraudulent supplements or treatments that would actually hurt your chances rather than help your chances of getting pregnant.
Okay. Samantha would like to know, what specific tests would you recommend to diagnose infertility?
Okay. So Samantha wants to know, what specific tests do I recommend to diagnose infertility? Well, there are so many tests that can be ordered and performed, and this is usually commercially based. In other words, if a doctor orders $5,000 or $10,000 worth of testing, then he gets money for doing nothing that really helps you very much. So I found, obviously you have to have a sperm count, just one simple sperm count to make sure the husband has sperm. And for the wife, the most important single test is a really accurately performed ultrasound with an antral follicle count by a really good technician who is not in a hurry and takes the time to count all of your small follicles, because that really is the best way of telling your ovarian reserve. And also, 3D on the ultrasound can tell us if the uterus is normal, if you have dilated blocked fallopian tubes. So that one ultrasound, if it's really a good machine and a good technician and not performed in too big a hurry by someone who's looking just for simplistic cysts or something, then that's the most important single test the woman can have. Now, I mentioned sperm count and ultrasound. And the third most important, which is really important and neglected, is, what is your age? Now, I know that's not a test, but the age of the female partner is the most crucial thing we can have. Then the menstrual history is important. It doesn't cost anything to know your age or your menstrual history. irregular cycles in a young woman that's been trying to get pregnant for over a year, who might even have facial skin problems, maybe an elevated testosterone, this irregularity of cycles is really a clue to the fact that she's not ovulating. So I'm mentioning really simple things. Now, you can get $10,000 worth of things like laparoscopy and hysterosalpingogram and tons of hormones and AMH and FSH and LH and progesterone and DHEA levels. You can have all that done. You can get sperm DNA fragmentation testing done. There are countless tests, but they're really commercially based, and they're not going to really help you in figuring out your infertility any more than the simple things I just mentioned.
Okay, we have a question from Brandy. She says, my fiance has retrograde ejaculation. We have been together for 4 years. He had testicular cancer 9 years ago. What is the chance he has live sperm?
Okay, so Brandy has a very good question. Her husband has had testicular cancer 9 years ago and has retrograde ejaculation. What can they do? Well, we've dealt with this for so many years. The retrograde ejaculation is generally caused, he probably had a retroperitoneal node dissection, and that would cause a paralysis of the sympathetic nerves, so that when he ejaculates, it goes backwards into his bladder rather than forwards. That's usually the cause of retrograde ejaculation in someone with a history of testicular cancer. And the treatment is very, very clear. Sperm production will be fine. It won't be hurt at all. So you can try to make the ejaculate go antegrade by putting him on some sympathomimetic drugs, we call them, like cold pills actually. And we used to do that in the old days, but it can be terribly difficult and you get bad quality sperm. All we have to do, and this is what we should do, is testicular sperm retrieval, local anesthesia, retrieve sperm from the testes, and do ICSI, that is injecting sperm into the wife's eggs. So it's IVF with testicular sperm retrieval. That's the clearest, most direct way to do it, and that will be successful. There's no problem with this sperm production, I'm sure of that.
Okay, Kathy would like to know, is AMH or FSH helpful in determining fertility?
Okay, so Kathy wants to know these blood tests I talked about briefly earlier, AMH or FSH particularly. Well, FSH clearly is not reliable. FSH is follicle-stimulating hormone secreted by the pituitary gland, and generally when you have less eggs, the FSH goes up. But the FSH doesn't really go up until your ovarian reserve is really, really way down and you're close to menopause. So FSH isn't really very reliable at all. Day 3 FSH, we talk about it all the time, isn't reliable. AMH is more reliable. That stands for Anti-Mullerian Hormone. And the Anti-Mullerian Hormone is reflective of the number of antral follicles you have. But, frankly, the testing for AMH, the platforms for it are unreliable and variable and open to some question. So it's okay. Much more reliable is if you have the antral follicle count done on ultrasound, as I mentioned earlier. But with a good technician who's not in a hurry and takes the time to really count all those antral follicles, I think that's the most reliable test of ovarian reserve. And AMH is fine. In fact, for scientific papers, we always have to include AMH. But actually, AMH, though better than FSH, is not as good as a good, properly performed antral follicle count on ultrasound.
Okay. Michelle would like to know if you believe DHEA is helpful.
If what is helpful?
DHEA.
Oh, DHEA. This is such a common misnomer. It's all over the place. It's such a myth. So there finally was a randomized control trial that was really good. It was reported in Finland at the European Society of Human Reproduction, which is the largest reproduction meeting in the world every year, and it was last summer. And it was very, very clear that DHEA absolutely had no effect on improving the egg quality, although it's a common myth that older women who we know have eggs that have a lower live birth rate or pregnancy rate per egg, would be improved by administering DHEA, which is just a male hormone. And in fact, the reason people talk about DHEA is it can be given without a prescription. It's just called a dietary supplement, which is kind of stupid, but it is. And therefore, there's no FDA regulation of it at all. And it's just another one of these dietary supplements that doesn't do any good. But worse than that, because it is a male hormone, DHEA can even reduce the egg quality. So no, DHEA is not only a waste of your time and money, but it could be negative.
Okay. What medications are usually prescribed with mini IVF?
Okay, so mini IVF is a protocol that started out in the early 2000s, and we borrowed it from the Japanese in 2003, and then I think we improved it quite a bit, so it's very reliable now, though it was very tricky and very innovative originally. Believe it or not, it's basically Clomid. This is an ancient 70-year-old drug that it's an anti-estrogen, so it fools your pituitary gland into thinking there's less estrogen around, so your pituitary increases its release of FSH and LH, and that's very, very important. Now, Clomid is given all the time to infertile women. The pregnancy rate's very low in the usual context because it has a negative effect on the uterine lining as an anti-estrogen. And often there's not even ovulation that occurs. But if you use Clomid to get a mild elevation of FSH and an equal elevation of LH, then the FSH is important for egg recruitment, and the LH is extremely important for egg quality. And so you get an equal and almost physiologic mild elevation of FSH and LH. So you really do get the best quality eggs with this mild stimulation with Clomid. Now, as you're beginning to form follicles and your estrogen goes up, however, the FSH will begin to come down. And so we'll supplement with an extremely low dose of FSH, 150 IU every other day, beginning on day 3 or day 5 of Clomid. And that's it. And then we trigger your egg maturation with Lupron, which is also physiologic, which causes you to have a natural LH surge, rather than 10,000 units of HCG, which is very unnatural and can hurt some of your follicles. So it's basically just Clomid low dose. Don't go to a high dose. We've experimented with that. It makes it worse. And extremely low dose every other day of FSH. And that's it. So you really don't have the awful symptoms one might anticipate with hyperstimulation for IVF. And yet we get better quality eggs.
Okay, we have a question from Cherie. She said she wanted to know, can you tell her more about mini IVF for women over 42?
Okay, so the question is, what about mini IVF for women over 42? Well, we have published just recently a huge statistical analysis of over 10,000 cycles of pregnancy rate per egg, which is not the usual metric people talk about. Pregnancy rate per egg at various ages. And so we have that data for women under 35, where the pregnancy rate per egg is anywhere from 28% down to 18% per egg. And then once you're over 42, it goes down to about 6% to 8% per egg. And we even have some pregnancies with patients' own eggs at age 46 and 47, but it's maybe 1% or 0.5% per egg at that old age. But with eggs that are 43 and 44, if you can accumulate enough embryos, not by hyperstimulating, because you really can't get any more eggs anyway with huge doses of gonadotropin. All you do is ruin the eggs you can get. But if you can maybe accumulate through 3 easy cycles of mini IVF, or even 5 easy cycles of mini IVF, then realize that we can get a pregnancy rate and live baby rate that's pretty much equivalent to a young woman's. Because even for a 43-year-old, it would be 6 to 8% per egg. And what if we wind up with a total of 10 eggs over the course of 3 cycles? Well, then we can get a good pregnancy rate of 40 to 60%. So it's not as high as a young woman, because in a young woman, 1 cycle would give us a 60% pregnancy rate, per treatment cycle. But we can get up to that pregnancy rate with several mini IVF cycles that are easy to take and less expensive.
All right. Kim would like to know, her husband had a vasectomy reversal about 4 years ago. It didn't work, and she wanted to know what would be the likelihood of you doing a redo reversal and it working.
So what's the possibility after a vasectomy reversal has failed of doing a redo of the vasectomy reversal? Well, certainly previous failure doesn't have any impact on us because vasectomy increases pressure in the male's reproductive system, which causes unfelt blowouts and perforations in the really delicate ductwork called the epididymis that's close to the testicle. So a failure of vasectomy reversal is generally that just the vas was put together, but there's still unrecognized blockage in the epididymis. So, I mean, we would have a 95% success rate if we bypass that epididymal blockage. Vas-to-vas repair, in fact, is a very, very low success rate these days, no matter how well it's done, because vasectomies have been done in such a tight way. Pressure buildup is quicker and faster, and so you have epididymal blowouts in the majority of men. But if we bypass those epididymal blowouts, then we have a really high success rate. Furthermore, whenever we do this, because there's a 5% failure rate, we'll freeze the sperm. I mean, we would never dream of doing a vasectomy reversal without freezing the sperm as long as you're in there. And so that sperm is always available without any further surgery for the male for doing IVF and ICSI with the wife. Now, if the husband is just afraid to go through another operation, and maybe it was painful before, we can always do a sperm retrieval under local anesthesia with IVF and ICSI. So that's certainly an option. But redo vasectomy reversal should be just as successful. And probably what happened was, in the original vasectomy reversal, they only did vas-to-vas, and they didn't really think of going to the epididymis.
Okay, Kristen said she and her husband have been trying to conceive for about 5 years. They're in their 30s. They've tried multiple IUIs, and they did an IVF procedure last summer. She did get pregnant, but she had a miscarriage. She says she's very healthy. Her husband has had some issues with the sperm, but they say it's good. She wants to know, what next steps would you recommend for them?
Okay, so she has Kristen has a long history of 5 years of infertility. And they've gone through multiple IUIs and even an IVF cycle. Did she say what happened in that IVF cycle?
She did not. She did say she got pregnant, but that she miscarried.
Just miscarried, okay. Well, so first place, I think IUI, which is really popular, and people go through multiple cycles of IUI. IUI is really not very successful. I would not have wasted time while her eggs are getting older, from age 30 to 35. I would not have wasted time with multiple IUI cycles. IUI is an interesting history. It was started in around 1983 or 84, and I was an infertility doctor there, microsurgeon. No one really in this country felt they could do IVF very well, except at the Jones Institute, and everybody felt inadequate because it was maybe England and Australia and Israel, and that was it, where there was any IVF being done. And people felt inadequate, the doctors, and so Val Davijan from USC came up with this idea, well, we'll wash the sperm and we'll take an infant feeding tube, because there were no IUI catheters, and we'll put this infant feeding tube in the uterus, and that'll be just as good as IVF. And they reported these ridiculously high pregnancy rates, which really weren't correct, and that was also reported by Jeff Scher, and it was just completely ridiculous, 47% pregnancy rate with IUI, hyperstimulation. Well, the truth is, I preceded all that, and I know what happens. IUI does not improve the chance of pregnancy unless you're giving hyperstimulation with gonadotropins and hormones. So timed intercourse with gonadotropins is as good as IUI, and you don't have to go through the medical treatment of IUI. So IUI is a complete waste of time. Now IVF, okay, she waited till she was 35, Kristen did, and I understand that. Doctors put her off. Miscarriage can happen at age 35. 20% of pregnancies end in miscarriage. I would recommend she try IVF again and not waste any time, because our study that I talked about earlier shows that the pregnancy rate and the live baby rate per egg begins to go down after age 35. And so she shouldn't waste any time in going through another IVF cycle. But I would recommend to go for better quality eggs and go with mini IVF.
Okay. Adrian would like to know, what is the cutoff for doing mini IVF here at our office?
What is the cutoff, like age cutoff for doing mini IVF?
Yeah, like age cutoff.
Well, it depends. The age cutoff really depends a lot on the patient being really well counseled. Now, most centers won't do any IVF on a patient over age of 42, but the only reason for that is they want to get higher pregnancy rates that they can report, which we have to report to the government, to CDC, and they use that for marketing. Now, it is against the law to use those pregnancy rates for marketing because patient populations differ. But, so it's against that law, the Wyden bill. But everybody violates that law except us. And honestly, they all violate it, and they will not do you over age 42 for that reason, so that they can game their results and do selection. And they'll do IUI on you till the cows come home, because they can make money doing IUI, but they don't have to report that to the government. So, so that's just the background, you know, of cutoffs. So we just have to inform you what the pregnancy rate is. Now, we haven't had pregnancies yet in any women with their own eggs over age 47. So for sure, 47 is the cutoff. But we want to warn people that the pregnancy rate per egg does really begin to go down at age 43 and is very low at age 46, as I mentioned earlier. But we certainly have pregnancies and babies with women's eggs who are 46. I am, by the way, not against donor eggs. You know, if you can't do it with your own eggs, we have never had an unhappy case with people that have resorted to donor eggs. And I could talk about that if someone wants to know about it, but I think the reason is that what you care about most is personality, character, intelligence, and emotional stability. And that really comes mostly from how you interact and bond with that baby in the first 2 years, maybe 3 years of life. So, but most couples want a baby with their own eggs, and so that's what we do. But if you're 47 or 46 and don't want to have a low chance of pregnancy, then I'm not against donor eggs. But after age 47, I think it has to be donor eggs.
Okay, this is the last question. It's from Brittany. She says she's 24 years old and has been recently diagnosed with premature ovarian failure. Is your office familiar with this? If so, what are my options?
They want to know if our office is familiar with premature ovarian failure, and she's 24 and just was diagnosed with premature ovarian failure. We wrote the book on premature ovarian failure. We did the first ovary transplants for women with premature ovarian failure in 2003, and we're very famous for that, and we've really studied that quite well. And we're doing a lot of research on it as well. So what we found with all of our ovary transplant experience, both fresh and frozen, is that as your number of eggs go down, as your ovarian reserve goes down, the rate of follicle recruitment also goes down, and it's a way your body has of trying to delay your premature ovarian failure despite having not many eggs. So what happens is, at some point, when your number of eggs have gone down a lot, you don't recruit any follicles at all, and there's still some eggs left in your ovary, but they can't get out. So if your premature ovarian failure has been, say, in the last few years, very recently, then we would recommend doing an ovarian autotransplant. We would take off the ovarian tissue, transplant it back, and that way we'd reduce the pressure, the tissue pressure, and try to recruit follicles that aren't being recruited now. So that would be what we would do, other than, of course, donor eggs is always an option. But that would be what we do. Or, you know, if you have an identical twin sister, we'd readily do an ovary transplant like we've done many of, and that would really work extremely well. Now, you do have to have a workup. You do have to have Fragile X tested to make sure you're not a Fragile X carrier if you have premature ovarian failure. But the vast majority of women don't have that. And we're still studying the genetics of premature ovarian failure, and we're doing an ongoing study on it now. So we don't understand it fully well, but we know that we can treat it in this fashion. Is that the last question we have right now?
Yeah, that was the last question.
Okay, so I'm Dr. Silber, Sherman Silber, Director of the Infertility Center, St. Louis, at St. Luke's Hospital in St. Louis, Missouri. And we'll be doing another Facebook Live. We'll be doing it every month, and we'll let you know about it. And just get your questions ready. We'll answer any questions right off the cuff. Thanks.